Good morning to everybody, and welcome to this week's clinical meeting. We have five speakers for today, and I'll call Dr. Abhay from Medicine 1, the Masquerader'S Odyssey.
Good morning, everyone. So I'll be presenting on behalf of Medicine 1. So this is a patient who came to our OPD, Mr. S, a 40-year-old tailor from West Bengal, who came with complaints of fever on and off for the past 6 months, mainly low-grade fever associated with night sweats. He was also having this cough with expectoration going on for the past 6 months. Small quantity, but which complained was blood tinged often and had EC fatigability for the past 3 months. No history of TB or contact with TB, but he did complain of weight loss, which was not significant. He was also known diabetic for the past 4 years, which on index presentation had osmotic symptoms. Mother had a history of diabetes, and he was on oral medication, which was not regular. Otherwise, no past significant medical or surgical histories. He was a smoker. He was smoking around 8 to 10 cigarettes for the past 8 years and occasional ethanol user. So on examination, he was found to be underweight with fairly normal vitals, and he was afebrile. General physical examination showed that he had pallor with grade 1 cubbing, and he was severely emaciated with temple hollowing bilaterally and loss of buccal pad of fat. On systemic examination, on central nervous system, he was found to have absent knee and ankle jerk with absent joint position sense and vibration sense. Respiratory system examination showed bronchial breath sounds, which was heard in the right mammary and infraclavicular area. And on abdomen examination, he had right hypochondriac tenderness on deep palpation. So summarizing, this is a 40-year-old male diabetic with chronic fever, cough with bloody expectation, and EC fatigability. On examination, he was found to be cachexic, underweight, having pallor, clubbing, and right upper zone bronchial breath sounds, and right hypochondriac tenderness. So the differentials which we considered were pulmonary TB, chronic lung abscess, probable malignancy, the lung being the primary, or an aspergilloma, or an bronchiectasis. So this was the initial investigations done on presentation, which showed leukocytosis with neutrophilic predominance and a normocytic microcytic hypochromic anemia, with the LFT showing elevated alkaline phosphatase. And he also had a hypoalbuminemia. So a biopsy which was done, a CT guided biopsy from the right middle lobe, because on X-ray this was the X-ray which was taken on presentation. So there was a right middle zone perihilar patch which was seen, which was later biopsied. So the CT guided biopsy of this showed mild to moderate peribronchial and interstitial chronic inflammation with fibrosis and necroinflammatory debris. However, there was noted to be no granuloma seen. The right middle lobe culture, fungal culture also sent, was found to be negative for fungal elements. 2 blood cultures done simultaneously also showed no growth. It was also evaluated for expert on the sputum, pus, and the biopsy samples. All of those were found to be negative. A CT thorax, abdomen, and pelvis was done in view of his complaints, which showed a hepatic abscess, which is involving the 8, 7, and 5 segments of the right lobe. He also had post-infective sequelae in the apical and posterior segments of the right upper lobe and anterior segment, the right lower lobe, with some right borderline hilar lymph nodes and minimal free fluids in the abdomen with mesenteric and subcutaneous fat stranding. So overall, there are features of infective etiology which was suggested with a hepatic abscess and a consolidation in the right middle lobe on imaging. Ultrasound, which is also done, showed a similar ill-defined hypoechoic areas in the right lobe, suggestive of probable liver abscess. Yeah, so the pus culture, which we later grew Klebsiella, which was string positive, with markers of RMPA, RMPA2, and IUCA, which are genetic markers which are positive, suggesting it's a hypervirulent variant of the Klebsiella. This was the second sample which was cultured, which also grew a Klebsiella. So talking about Klebsiella pneumonia, it's an opportunistic gram-negative bacteria encapsulated and anaerobic, which is commonly seen as a common cell of the human GI tract, often causes nosocomial infections, predominantly UTIs, pneumonias, and bloodstream infections. So there's a particular variant of this called as hypervirulent Klebsiella, first reported in the 1990s from Taiwan. It's very predominantly known to cause severe community-acquired infections, especially in healthy individuals, and can have metastatic spreads. So they can often present with pyogenic liver abscess, like in our patient. They can also have abscesses at other sites. They can have pneumonias, meningitis, endophthalmitis, and necrotizing fasciitis. So the hypervirulence in these organisms are attributed to their enhanced capsule production, their siderophore overexpression, and plasmids which carry virulence genes, such as RMPA2, A and 2, which were found in our patient also. So this is a pictorial representation, which, like you see on the left side, is showing the abscess in the liver, and again the lung, which shows multiple abscesses in the right side. So the definition of hypervirulent Klebsiella is often based on a combination of clinical and microbiological characteristics. Not all of these hypervirulent strains are hypermucoviscous, and sometimes a normal classical Klebsiella can also have features. So often hypermucoviscosity is the one which indicates expression of these capsular polysaccharides, which are responsible for the hypervirulence. And the markers for these are the one like we discussed, RMPA and RMPA2 and IUC, which are often tested for. So if these are absent, they are often told to be lacking in hypervirulence. So sting test is one of those screening tools which are used to identify these phenotypes for hypermucoviscosity, and which is a key characteristic of many of these hypervirulent strains of Klebsiella. So what they do is they culture a colony of these organisms on blood agar at 36 degree, and then using inoculation loop, they try to stretch it. So if there's a formation of a viscous string more than 5 mm in length, it's often identified as a hypermucoviscous strain. So this is often a phenotypic screening tool. So like you see, this is a pictorial representation of the same. So the sensitivity is found to be around 66 to 90%, but found to be not so specific. Again, like we said, some classical Klebsiella could also be hypermucoviscous, but again, not virulent because they often lack these markers which we discussed earlier. The gold standard for hypervirulent Klebsiella remains the detection of these virulence genes by PCR or whole genome sequencing. So why is it clinically relevant? So identifying these hypervirulent Klebsiella is very important in identifying the patient characteristics and outcomes. So it also helps in identifying possible unrecognized sites of infection, which we can often miss and could also manifest as occult abscesses, which would later require drainage, extended antimicrobial therapy, and site-directed treatment. And these organisms are very known to cause relapse, and predominantly because they form biofilms and often require prolonged treatment, unlike the classical Klebsiella strains. So in our patient, after consultation with ID, he was started on injection meropenem for about 6 to 8 weeks and was told to follow up in our OPD. He was also planned for a pigtail aspiration of the abscess once it liquefies. So the learning points, hypervirulent Klebsiella causes severe and disseminated infections. And these are often seen in immunocompetent individuals, unlike the classical strains. And often they're found to be antibiotic sensitive, unlike the other ones. And recently they have found that the resistance is also emerging in these hypervirulent strains where they're found to have antibiotic resistance, but often they're found to be antibiotic sensitive. And often early recognition becomes a very important criteria because they can clinically deteriorate if not picked up and requires prolonged antibiotic course. Now, sting test is a very useful screening tool for these organisms. But like we said, genetic biomarkers remain the gold standard for diagnosis. And nucleic acid amplification test, if developed, could become a very highly accurate point of care diagnostics, which is not developed so far, but the markers can be used for forming a NAT test. Yeah, thank you.
Thank you. Any questions? Thank you for highlighting, that hypervirulent is not the same as the hypermucoviscosity. Sure. Anybody? Okay, if not, we'll go from medicine 2.